right. Hello, everyone. Good morning. We're excited for you to join us today. My name is Boyter. I'm a research director both at the KLAS Research. We're going to talk a little bit more about KLAS Research in a moment. But again, as those of you who are just joining us, we appreciate you joining today. We're here to talk about bridging the divide between payers, providers, vendor service firms, organizations. There's multiple levels of intersectionality that exist. So we're going to be talking through a couple of those things. We have some presentations today with various teams and stakeholders across the continuum of payer-provider and beyond that we're going to be talking a little bit more about. I'm joined by my colleague today, Aurene Wilford. Aurene, would you...
Hi, everyone. I'm an Insights Director here at KLAS, and I work in the Payer-Provider Collaborative.
Excellent. So I wanted to share just a little bit about who KLAS Research is, what we do, for those of you who may not be familiar. So KLAS Research, I like to joke that we are the oldest startup that you probably haven't really heard of. So KLAS Research is a 30-year-old healthcare-focused research firm. We are third-party, totally independent, and we worked tirelessly to try to figure out how do we actually measure performance amongst vendors, service firms, payer groups, to give clear and accurate, impartial perspectives on where things are going in the industry, decisions that are being made, et cetera. We talk with over 27,000 healthcare providers every year, and we gather through anonymous feedback their experience with those different vendors, those teams that they engage with. We then annotate, put all that data together, analyze it into various reports. One that you may have heard of, or if you walk the floor here at Health, you're going to see people with a booth that might have a best in class spelled, KLAS, because it's right there. By the way, before you ask, KLAS is not the name of a German art house film, okay? Just if you're wondering, like, KLAS, what is that? KLAS is actually the letters Kent, Leonard, Adam, and Scott, the four founders of KLAS, and that's why it's KLAS. So our best in class report comes out every year. We measure over 900 service firms and vendors in that report. And then we also have about 90 specialty market segment reports, everything from agentic and generative AI, CDI, technologies, consulting, all across the spectrum. In the last few years, we put together and launched what we call our K2 collaborative initiative that Aurene has been instrumental with, and myself as well. And really the purpose of the collaborative was to provide, again, transparency and insights. I like to say that we're a little bit like Switzerland. We try to be impartial. We bring all the players together and allow them to talk things through. We do this through a couple of different vectors, through various reports, and then we also have what we call our K2 Collaborative Summit, which we hold in Salt Lake City, Utah, May 5th, 6th, and 7th. We'll talk more about that in just a little bit. But Aurene is going to talk through some of the goals that we have, and Aurene, I'll have you kind of share a little bit more about this. There you go. Of course.
Like it says on the screen, the K2 Collaborative aims to improve efficiency in healthcare by encouraging payers and providers to connect and engage on shared goals. This is just a slide showing you our summit in May. It's the 5th to the 7th of May in Salt Lake City. If you are one of those payers or providers that is interested in collaborations with each other, then this is the summit for you. It draws a tremendous amount of technology vendors that are invested in trying to resolve issues in healthcare. One of the things we offer at the summit is presentations on points of light. Those are some of the reports that we write, and you're going to see 3 presentations today. These points of light are where payers, providers, and technology vendors have come together to resolve issues in healthcare. And last year there were 25 reports that were presented and were written. And you can see what they focus on. A large amount of them focus on various parts of value-based care, prior authorizations, improving data exchange and data sharing between payers and providers. And some of them also focus on the intersection with payment integrity and revenue cycle. You know, we have run the summit for the last 4 years, and every year we ask the same survey questions, and more than ever, the gap in trust is growing. Well, distrust, should I say. The gap in distrust between payers and providers is growing. Everyone is very aware of the ROI and the financial constraints, and this drives a lot of that. So we have found on that last chart, you will see there's this sharp spike there in the chart showing that payers and providers are turning more and more to technology partners like you'll see today with Epic, Leavitt Partners, Ensemble, Anterior, who are bridging the gap between payers and providers and helping them to align on goals.
So this is something, if I may just really briefly, I think we all accept and appreciate that the reality of the current marketplace is that distrust is increasing, not decreasing. So again, what Points of Light, the K2 event, these other things, really all of this has a singular focus: to have aligned decisions across the market participants, make sure that everyone in the industry, because there are a lot of different stakeholders. And when I talk with payers, they talk about overcoding. When I talk with providers, they talk about downcoding, right? These are two sides of the same coin, really trying to find the same consensus. And we have the same issue with AI, generative AI, other tools being deployed to deny claims. We have other tools that are being deployed in ambient technologies and other things to provide better accuracy and quality of claims. So all of these things are really coming at these issues from two dichotomous directions. So working together to highlight those improvements, that's what Points of Light is all about.
Okay, so first up today, we are going to have one of our subject matter experts, Jenn Hickenlooper, and she is a Senior Insights Director at KLAS with a lot of experience, and she will be speaking to you directly and sharing with you some really interesting data on payer and provider IT trends and their priorities. I'd like to welcome Jenn onto the stage.
Great. Okay. So today we're going to go through a few different healthcare IT trends that we are seeing at KLAS. Every year we do some research with Bain, where we talk to healthcare executives to find out where they are investing and what some of their biggest challenges are and priorities year over year. So in this year's research, what you can see is we spoke to about 100 providers and about 100 payers to get their perspective. Most of these are executives in these health systems or health plan organizations. And then they're from a really wide variety of different types, as you can see from our breakdown over there, from small to big organizations. So when we're looking at where IT is as a spending priority, both payers and providers still feel like they're going to be growing their IT spend year over year, which is really interesting because we know that they are feeling a lot of pressures right now with margins and costs in different places, but they still feel like spending on their IT is going to give them a lot of bang for their buck year over year. So when we look at why that is, for our providers, which are on the left-hand side, they're really looking to consolidate their vendors and then really invest in new areas is their top reason for saying that they're going to invest in IT. And then when we look on the payer side, they're really wanting to update their solutions with new technologies that have come out year over year. Great. And then I'm going to delve into the provider priorities a bit more of where they are really talking about spending year over year really quickly. So when we look at our providers, revenue cycle management is the really number one place that they are thinking to spend, followed by clinical workflow optimization. And a lot of that clinical workflow optimization is really in the physician's workflow. So places like ambient speech, where we have seen a lot of investment, we expect to continue to see a lot of investment there. And then the EHR has actually risen in priority, and so we're seeing that as the top 3 priority. And then when we look at who they are looking at to invest in, so typically provider organizations choose to invest in their EHR first when their EHR owns or has that tool available. And so you can see that for things like clinical workflow optimization, clinical tools, and patient access, they're often looking to their EMR first, Whereas other places like your ERP or governance, risk, security, IT infrastructure, things like that, more likely to go with the best-of-breed solution. When we're looking at that EHR piece, we do know that some of the EHRs have talked about investing in things like ambient speech and rolling out tools there, so we do think that there could potentially be a shakeup there. We have some research on our website if you're interested in reading more about that. And then when we look at where our providers are seeing the biggest investment for Gen AI, revenue cycle and clinical workflow optimization that I sort of touched on a moment ago are really the place that we're seeing a lot of energy. So with revenue cycle, there's a lot of churn happening there. So we're seeing solutions like prior authorizations being more automated is a place that both healthcare providers and payers are looking at to find synergies. Obviously, if there's auto denials, there can be a lot of frustration there. But when it's more, we're trying to approve things quicker, and then we put a human in the loop for the denials, things go pretty well right there. Patient engagement is another place that we're seeing a lot of investment. We also published a report recently called, the name is escaping me, but it's around all of the federal government changes and what healthcare providers are trying to do. And one of the pieces that we're seeing is they're leaning into value-based care, which in that case, patient engagement becomes a higher priority because they are wanting to engage their patients to proactively treat and make sure that they are closing gaps in both their quality and risk types of care. Great. And then one other thing I want to note, though there's a lot of optimism with rev cycle and clinical workflow optimization AI, we actually aren't seeing that being a high critical decision-making factor when healthcare providers are investing in that. Meaning it's a nice to have, it's not a must-have yet. Great. And then one more piece I want to touch on for AI. So when we're looking at why providers may be hesitant to adopt with AI, we're seeing that regulatory and legal considerations are the number one reason, along with cybersecurity, that they may be hesitant to adopt, which means that this is why they are going into things like rev cycle, clinical workflow optimization, because those are lower risk, whereas if we start getting really into clinical diagnosis and different pieces there's much higher risk, and so they are much more hesitant to invest in tools like that. Great. I'm going to ask for questions at the end, but we're going to switch over to payer priorities now. So payers, their top IT priorities that they're really looking to invest in right now is care coordination and utilization management, along with network optimization and plan design. So when we are looking at the why for these, so there are a lot of changes happening with federal government requirements, and really wanting to try and reduce some of the administrative burden of care management. And so our health plans are looking to be able to do things like care management in a more efficient way. When we look at AI tools on the payer side, care management comes up as one of the top areas that health plans would like to invest in. However, we have not seen a lot of tools in care management that have been adopted yet. And then on network optimization and plan design, health plans are more frequently talking about cost and other barriers like that. And so they're really wanting to make sure that they're optimizing their networks for their members while at the same time being cost effective. And they also are leaning a lot more into value-based care and risk contracts, and so they want to make sure they're able to really manage their population's needs, so making sure that they have the right doctors in the right place so that their members can get care. And then when we look at payers, they're a little bit different than providers. They don't typically lean into their EMR for first choice. They actually are much more likely to choose a best-of-breed solution. And when we look at national plans, as you can see on this chart, they are much more likely to build in-house tools. Sometimes that works out well, other times that does not work out as well. And then one other piece that we're seeing with health plans is rather than buying I'm going to say point solutions, they are starting to look at more enterprise solutions that can be used either across different lines of business or across different pillars per se. Like I can use my vendor for both quality and risk and make sure that I am being able to see data similarly across those teams so I can make better decisions for my members. And there's still this piece of wanting to diversify because of the Change Healthcare incident, but in general, they're trying to, I'm going to say, consolidate without fully consolidating their solutions. Great. And then when we look at our payers, when it comes to AI, many are actively looking to develop an AI strategy, and this has payers and providers, I believe, on it. So providers are on this side, payers are on this side, and you can see that both are more actively looking to develop an AI strategy. And when we look at where payers are most likely to invest, again, talking earlier, we mentioned member care management, navigation, those are really top areas. Quality and risk is another place we are seeing a lot of adoption. However, those tools have had AI in them for quite a while because they had NLP and machine learning models to try and manage the risk of the population. Great. And then similarly to the payer side, you can see that the regulatory and legal considerations are really that biggest barrier to investing. They really want to make sure that they are not making bad decisions and becoming liable for them. They also often worry about hallucinations and the safety of their members. And then I want to touch a little bit more on AI across healthcare. So we've been asking questions on AI since January this year, so we have a lot of data. This was aggregated in June, but what we are really seeing is that there is some silos within healthcare organizations. So some people know what AI is happening, and a lot of people don't know what AI is happening in their organization. So it's very departmentalized and often stuck in pilot mode. So I think one of my slides disappeared. Anyway, if we looked across healthcare organizations, what you'd be able to see is that though many healthcare organizations have maybe like an executive who can say what that broad AI strategy is, there might be another executive who at the same org says, I don't even know what we're doing with AI. And so one of the things that we recommend both in provider and payer organizations is to be really clear and communicate what is going on so people really understand what that strategy is with AI and where you're trying to build efficiencies. When we look at clinical and, again, administration operational tools, which is where rev cycle tools sometimes fall along with our RCM claims tools. Those are very frequently being adopted. Imaging, we think, would be a lot higher, but typically only people in imaging talk about imaging. So that's just another piece to note. We have a whole report on AI and imaging at KLAS, and it shows it's actually one of the more higher adopted places. And then when we look at what we mean by clinical, ambient speech is really the top place that we are seeing adoption. We're seeing a ton of outcomes. Mac, who is back there, could talk about this all day, but it's really decreasing physician burnout and reducing pajama time, and physicians are really able to get their notes closed and push through a lot quicker than they used to because of ambient speech. And it will be really interesting to see in the future as we are getting more full capture of what is happening in these appointments. If some of these tools, for instance, like retrospective risk tools that are going and trying to find things that might have been missed in the note, if those become less important because we are actually capturing everything up front. So we'll see what the future brings there. And then, I'm going to continue on. Here again is another view of really showing where ambient speech is. So many orgs were currently using ambient speech, and we also had many that were planning to adopt ambient speech. And then there's a long tail of other solutions that were mentioned. Yep. And then I'm going to show this slide as well. So Microsoft, Epic, and OpenAI in this AI research were most commonly they were the most common ones that came up. And one thing I think we are noticing is health systems in general are really wanting to lean into vendors they're already using, who they already have security agreements in place, and they really feel safe to be using these vendors because they have been using them for a while. They are much less likely to go and use a best-of-breed vendor as they are implementing these tools. I also would like to mention, as you can see on the bottom right over there, we had 467 vendors that were mentioned less than 10 times in this research. So there is this long tail of other vendors. And my last thing that we get asked about quite a bit is agentic AI. And when we look at how real agentic AI is in the healthcare market, of the 3,000 use cases that we had mentioned, only 17 of those were agentic AI. So do I think agentic AI may be part of the future? Yes. But is it real right now? Not so much. And I am out of time. So I would like to turn it over for questions for just a couple minutes, if any of you have any.
I saw a little bit of virtual care in your spend.
Mm-hmm.
What are any insights you could provide, virtual care or telemedicine spend?
And are we talking about on AI is where you saw the virtual care?
Yeah.
Yes. So I think when we're talking about AI, it would be similar to ambient speech in that it's able to capture all of the notes from the virtual care appointment, aggregate them, and then be able to put those into the EMR as a note is our main use case we see there. Yes.
Can you hear me? Okay. So I'm just wondering what you think of, or what we can reflect on a group here, is the expenditure on pop health. I think it was like 3 slides before, where the N was like 34, but the N for ambient speech was 344.
Yeah.
But maybe that's just the population size. I'm just surprised that the pop health piece, which could be so broad, was so low.
Yeah, so I think one thing to note about this AI data is we've been asking on all of our calls. And so I think typically when we are looking at things like pop health or risk management, typically the people that are going to bring up that they are using AI there are going to be people in that department, whereas like a clinician somewhere in like cardiology, they may be way less likely to be like, yeah, we're doing pop health AI. So that's one piece. Also, generative AI seems to be the more buzzy use case right now, hence why ambient speech is coming up a lot more, whereas things like pop health and risk adjustment have had AI tools in there for a long time. So they just may be less front of mind.
So I'm just going to make a comment then. I would not take that particular slide to really represent what the truth is out there. It's just a reflection of who is surveyed.
Yes.
Correct?
Yeah, I would
Because
say part of it is who is surveyed and also what was top of mind for them. Because we do have a lot of executives in here, but the use cases they're bringing up in their health system right now are the newer use cases that they are excited about driving outcomes more so than the historical use cases.
I actually participated in that study. I actually
Great.
gave my thoughts in that. And I would just add that the questions around pop health were probably, feedback, could have been more reflective of what a chief executive in a health plan would be looking at from a pop health perspective.
And I would say, I'm not sure if this was the exact one, because this is an open-ended question we've been asking on calls, which is, where are you using AI in your health system, and where do you plan to invest? So they're just really open-ended. Yes. Hello, Aurene. I'm going to hand off my microphone to you.
Thank you. I know there's still lots of questions out there. We have a booth, 4321. Please come and find us. We've got loads of data, and we can be sure to answer your questions there. I'd like to introduce the first point of light. It is Epic. So Jim McDermott from Epic. Please welcome them as they come on stage. David Lee from Leavitt Partners and principal of the Karen Alliance, a partner of the Karen Alliance, and Scott Phillips from Texas Health.
Good morning. We're going to introduce ourselves real quick. My name's Scott Phillips, and I'm with Texas Health Resources, which is a fully integrated health care system of 29 hospitals, PCPs, specialist urgent care in the Dallas-Fort Worth Metroplex.
I'm Dave Lee from Leavitt Partners. Leavitt Partners provides professional staffing services for the Karen Alliance. Karen Alliance is one of the HL7 fire accelerators. We focus on the B2C workflow. We've got about 75 members, including some folks in the room, so glad to be here.
Good morning, folks. My name is Jim McDermott. I work at Epic in software development, and I focus on payer-provider interoperability.
All right, so why are we here? We want to talk about a workflow that we have initiated and a partnership between our groups to help solve the problem of a frustrated consumer. We are seeing in the healthcare space, especially with patients dealing with their PCPs and their specialists in their hospitals, the disconnect they experience from every day dealing with Amazon or partnering with their bank, the ease of those workflows versus what they are facing when it comes to their clinical care. We deal with patients that don't understand why we do not have all the information that they have provided us several times, why there's silos of information, why there's a disconnect between the provider, the payer, the healthcare system. And so this was one of the several issues we were trying and have actively worked to solve. Another issue, of course, is the problem you can run into from an accuracy standpoint. When you're dealing with workflows that are based on manual effort or workflows that do not have correct data and information, that, of course, can lead to delays in care, delays in authorization, and delays ultimately with the patient. And so those are some of the things we decided to focus on and work with when it came to the payer platform and partnering with Epic. I'm sure many of those of you in the healthcare space, you see these trials, and we're excited to share this information because it has been a very good outcome for Texas Health and, more importantly, for the patients we serve. Let's go to that. There we go.
So I'm going to talk a little bit about the Karen digital insurance card and the digital insurance card IG. So this is part of what was leveraged in this pilot and this point of light with Texas and Epic. But it is a broader standard that was developed or started back in 2021. And this really came out of some of the work that happened during COVID, right? A lot of folks, including some in the room, again, worked on smart health links and smart health cards. And there was an interest among the community, especially among some of the Karen members, to say, can we take this one step further and have in fully fire resources all of the information that you would need from an insurance card, right? Instead of having in your wallet or in your app a PDF of your insurance card, can we have actual fire resources that can be exchanged back and forth? And so that was kind of the start of what we were hoping to do. In an open source way, go through the HL7 process and build out an implementation guide that could be used universally and interoperably, so that you could go from having a Blue Cross insurance card to a United insurance card to a Cigna insurance card, and have that information move with you. So what does the IG contain, right? And again, this is an implementation guide. It's not the actual implementation. We're going to leave that to the others to talk about. But it defines what the required data elements are on the card, right? What do you need? What does that look like? It maps those required elements then to the FHIR profiles, and then defines the consumer access use case. So again, and I just want to underscore this, Karen is exclusively focused on the consumer experience, right? So this is obviously, in many ways, a B2B data exchange. You're taking information from your insurer, and it needs to go into the registrar. But it's really to facilitate a consumer experience, right? I think all of us are aware of what CMS is trying to do at this point. There's been a lot of press around their activities with new apps and the pledges that are being made to kill the clipboard and how that's going to look and how that's going to work. And I think a lot of us are really, really interested in advancing this consumer use case to say, how can we make it better for the consumer to show up, right? We're in Vegas. There's a great Brian Regan stand-up about the clipboard. Why do you continue to give me the clipboard after all of these years? I've been coming to you for 14 years. None of my information has changed. I just want to see my doctor. And that's one of the things that we're hoping to do here, right? Kill the clipboard, have that digital information so that you can do easier things before you show up at the physician's office, when you're registering as a new patient, for all of those use cases. So we're really excited for what Epic has done with Texas to advance some of these pieces in real life production.
Great. So one of the things we set out to solve here is, I think, as you guys know, whenever you go see your doctor, one of the first things that you have to do is produce your ID card. And oftentimes that can be a time-consuming part of the process and error-prone. So what we've built over the last 6 or so years is a network for payer and provider interoperability called Payer Platform that's really looking at how we can deploy technology to meet some of these common pain points and administrative burden that is prevalent throughout healthcare. Certainly ID card exchange and the ability to solve some of these problems is one of those use cases, but there's actually much more that we do. So what does this actually do? It's actually pretty straightforward when you think about it. When you show up, maybe to urgent care, maybe to the emergency room, maybe to schedule your appointment, the network is actually going to be pinged to see if coverage is on file for any payer that's connected up, and it's going to create that coverage and register it automatically within the health system's Epic system. Do you mind looking at the next slide? And secondarily to that, we use the Karen implementation guide to say, let's not just send the discrete data that exists, but let's actually send a digital copy of that ID card. For many health systems across the country, getting that physical representation or that view of the ID card is absolutely paramount. One, to make sure you have all the information you need to accurately bill for that, but then also to have something to reference back to make sure that you have everything on file that you need.
So the goal, as you've heard, the benefit that we have is the actual digital version of this information. What does that provide? It provides the outcome of a quicker intake process for our consumers. It decreases the need for follow-up work. So many times on the back end of within the revenue cycle, you are trying to trace and find back insurance cards that the patient might not have had when they had arrived at the emergency room, or for some reason the healthcare system doesn't have it. This has really alleviated some of that extra effort to try to connect the dots. It has also painted a level of trust between the consumer and the healthcare system, because it looks like we are actually partnering with the payer, that we are acting as one team and it's not as siloed. We have your information, we're able to act on it, and we don't have to go through additional hoops or lean on you to provide this information for us. And on this screen, it represents all the different interactions we have taken within Texas Health through the payer platform in this effort. And what this slide really represents to me is a way of alleviating errors. Every one of these point of contact could be a potential error based on a manual workflow or somebody not entering the information correctly. Through this technology, we have the information, we have it in a digital form, and we're able to act on it quickly. Just an actual example, besides the faster intake process, is within our patient navigation referral management team. As you all know, specialists at times, especially in certain specialties, there's a long wait time for that patient to be able to see those specialists. And when you add the issue of incorrect insurance, that might delay the process, it compounds the issue. We saw within our patient navigation referral management processes such improvements because we had all the information quickly, accurately, and were able to act on that for the patient. And that was just one real-time example of how having this information electronically and within our payer platform has increased our consumer satisfaction, but at the end of the day has really increased the level of care that and trust we're able to provide to our consumers.
Now, as we look ahead, there are a few things that we've learned from the work we've all collectively done together. The first is that the consistency in workflow is so critical for us to affect change at the scale that we need to across the country to really reduce the administrative burden. So one of the things that we really focus on through the use of standards like Karen, as well as the work with a multi-payer solution, is to say, how do we make sure that when a front desk staff member at Texas Health is registering a patient, they get the same experience whether they have United or Humana or whoever it may be. And so it really is so critical that we move away from a hodgepodge of solutions from payer to payer and really focus on some consistency across the industry. And again, certainly the work on standards-based interoperability is a big part of that.
Yeah, and to that point, I'd just note that, again, with these implementation guides, and for those of you that work in the HL7 world, they're evolving and they're updated, and they need the feedback from real-life experimentation and feedback. So, again, we're really appreciative that this was a start, right? It wasn't, the Karen IG didn't cover everything that was absolutely needed. But also, it's an opportunity for us to now say what worked, what didn't work. How can we advance this in meaningful ways? And so as we go into an STU update, as they're called, and in the HL7 world, getting this feedback and understanding what was there, what wasn't there, what worked well, what didn't work well, is really important as we hope to advance these open source solutions, right? Because for these to scale everywhere, right, they have to be open source, or else we're just going to be locked in proprietary places again. So we really appreciate the feedback that has been given, and would invite anybody who's got additional feedback to get involved in the process.
Are there any questions?
Great to see the progress, having been a little bit involved in the beginning of Smart Health Cards. Excited to see congratulations on these milestones. My question is really about generalizability, right? You made the point that obviously, the IG is a spec, it's a standard for one aspect of this, but obviously Payer Platform does a lot more than that, broad set of use cases. We have an incredibly siloed, fragmented healthcare system, and we have, lots of different EHRs, we have lots of different payers. I want to, really think, and again, standards are foundational, but in my mind, necessary but insufficient. They actually need to be operationalized. I think one of the challenges is we end up, thinking about all of these different point-to-point connections for all these different use cases, and it's kind of crazy. We have 6,000 hospitals in this country, 500 payers. That's 9 million, matches times 100 use cases. That's 90 million, kind of use cases multiplied by those sort of pairs. So how do you really think about generalizing some of the efficiencies that you've demonstrated in this sort of, epic hospital to epic payer platform payer, but we need that across the healthcare system. And I'd ask you maybe specifically to think about the VA. One of the VA's challenges is community care. Right now, the VA, because Post-Mission Act pays for coverage, is a payer now when people go to Texas Resources or other regular hospitals. VA has never really been a payer. So that's an example of a health system and a payer that's sort of not on Epic, probably never will be, not a traditional payer, needs to sort of connect to every hospital. How do we generalize these solutions beyond a sort of Epic customer and Epic payer platform payer?
That's a great question, and I see really three avenues that we need to collectively work through as an industry to solve for it. One is certainly the advancement of standards, and there's a lot going on across the industry with Karen, with Da Vinci, to continue to create standards that can be worked and implemented by many different groups. The second aspect of scaling is really around network and governance. If you want to move away from a world of point-to-point interactions and really start to have that true ability where a health system can connect to any health plan or vice versa, you need to have a network and governance structure to support that. And what we think at Epic is really focusing on things like TEFCA to create that network and governance structure that can provide some on-ramps to start solving some of these challenges. And so we're really excited about the evolving use of payment and operations over the TEFCA network, hopefully in the year to come, so we can really start to see this stuff scale. And I think it's kind of a trust-building exercise, too. I don't think you can do everything at day one when you're creating a new governance structure or network for these types of things. We've got to focus on specific use cases, build success, build trust, and then continue to expand from there.
Hi. My question kind of builds on the gentleman's prior. That sort of payer network that you have built in there, is that something that outside of Epic can be tapped into, or is it similar to an insurance discovery transaction that somebody like Change or Experian has?
Yeah, so the question, is it something that other folks can tap into? Mm-hmm. Again, we really look at it in two ways, right? One is the standards-based exchange that exists is available for other folks to connect to. And so many of the things that are available within, for example, the payer platform network are also available via standards-based interoperability. I do think the way that you make this scale is focusing on getting those trusted networks built up across the country through things like TEFCA.
Yeah, and I'd maybe just add quickly, I think as CMS 0057 comes online, that's going to be a forcing factor as well, right? I think for better or for worse, a lot of the payers have not been required to have FHIR infrastructure before the interoperability and patient access rule. And the interoperability and prior authorization rule builds on that. It's not fully live everywhere. But for a lot of these, for the insurance card, to have that work, that payer has to be able to produce that at the front end, right? And so yes, you've got to be able to ingest it at the point of care. It's got to be, network-based and available. But we hope as more and more payers build that FHIR infrastructure, and as that FHIR infrastructure matures at the payer sites, that more of those can be produced, and that then we'll figure out how to do some of that ingestion. I'll be candid. I think a lot of the CMS interoperability framework activity that's going on right now, that was announced in July and is moving forward now, hopes to address a lot of that, right? I mean, they've got an entire category on apps that can produce or can ingest these cards, that can carry around in your wallet, and you can then produce them somewhere. We still have a lot of questions, I think, to the points that have been made. How does the provider ingest that? Where do they see it? The point-to-point connections isn't going to work everywhere, so how do we scale is the next question. But we have to have that foundation first, and our hope at Karen is, as some of these standards mature and as the regulatory timeframes come forward, that a lot of that will get worked out as well.
So there's a question, what's being done in this space for cost estimation? It's a good question. There's a heck of a lot that goes on already within the cost estimation infrastructure. I think certainly things that we can do to help facilitate more eligibility transactions to get accurate benefits makes a big difference. There's work that we've done to try to get more accurate estimates over time from Epic Health Systems when they're connected to payers over payer platform. I think one of the big questions that many of us have is what's going to be the future of something like the advanced DOB to help folks get a more accurate estimate that's adjudicated against the benefits that the plan has. I know that's been talked about for a while now, but I think that really is going to be one of the necessary solutions to this problem.
Yeah, maybe you can tell who the lawyer and the lobbyist is up here, because I keep going back to the government regulation of this. No Surprises Act, the OPPS rule that came out, some of those pieces that had good faith estimates or had advanced DOBs, we haven't seen a lot of enforcement around that, right? Society has had a hard time figuring out how do you produce those things, what's a shoppable service based on the cost report versus actually what's in the plan, and how do you test that against what's in where you are in your plan year. there is a lot of interest, I think, in this administration in pushing that forward. Obviously, we're in the first year of that, and they haven't been through a full rule cycle where they went through all of the processes on their own. So I would continue to watch that area. I don't have a good answer on when it's going to be, but there is certainly significant interest from this administration in advancing those consumer-centric priorities around more transparency in coverage, better understanding of where you are and what your costs may be.
Thank you for the session. Just really quickly, sorry, I'm over here. Maybe a little tangential to what you were just discussing, but snowballing off the previous class session where there's going to be a look at investing in rev cycle. We know that misidentification happens that leads to claims denials. Have you all thought a little bit around what biometrics could look like when you're checking in patients to ensure you have the right patient, reducing fraud, identifying the right insurance? And no is an okay answer, I'm just curious. I'm starting to hear more about it.
So biometrics may be a little bit too far. I think, Karen has done a lot of work in the digital identity space, right? And there was a proof of concept that was done 2 or 3 years ago with HHS and leveraging some of the federated model. And I think we talked a lot off stage about what needs to be centralized versus what needs to be federated, right? And obviously with patient identity and some of those things, there's some trickiness with what the government can and can't do. But there's a lot of opportunity, we think, for things to go forward with the private sector, right? And you've got a Cantera certification that different ID and credentialing service providers can use to say, look, our process gets you to an IL2 credential. And we can use that IL2 credential, link it to your digital insurance card, and move things around in really appropriate ways that, candidly, may be more secure than what we've done. There's a lot of nervousness to accepting an outside credential. We totally understand that. But we've already seen a lot of advancements in that space with Clear, with ID.me, in trying to advance some of those things. So there's some biometrics tie-ins to that. I'd go up maybe a level and talk about a federated digital identity program where you're accepting an external digital identity credential. And we hope that you can make those linkages back to this digital insurance card, make it, again, more seamless for the consumer who you're ultimately trying to help. So that patient matching can work, the rev cycle management gets a lot easier because you know that it was actually that David Lee that was in your emergency room. And so, again, maybe not the direct answer, but maybe the direction that I would go.
Yeah, following up with her, I just wanted to know, like in patient ID, with the various systems, it could be a mismatch. So how are you keeping human in the loop to make sure for erroneous identifications and workflow?
So is the question about patient identity and patient matching?
Yeah, patient matching.
Okay. You want to start there for this purpose?
Yeah, absolutely. So over the years, we built a pretty sophisticated system to try to match patient identity between different systems, both from a healthcare delivery perspective to enable interoperability as well as payer and provider interoperability. You are right, though. It is a challenge. One of the things that payers are not particularly known for is having up-to-date demographic information for their members, which makes matching a bit more challenging in this space. But it is something that we've been hard at work out for years and have some pretty good algorithms in place to do.
Okay, thank you, everyone. If there's more questions, you can grab them after. We really appreciate the efforts that you guys have done as patients, all of us. Thank you. Patient access is definitely problematic. I'd like to welcome our next presenters, Mustafa Sultan from Anterior, Dr. Rahul, and George from HealthHelp. They're doing very innovative stuff with AI and prior authorizations.
Hello, everyone. It's amazing to see so many of you here on a Sunday to talk about AI and prior auth, which I'm guessing many of you sat in the room actually, if you've been in this industry and these kinds of talks for the past few years, this is probably the 100th presentation you've seen of this type, right? And so I think it's really, really important to just break character for a second and actually just be honest about that. And then also to kind of start with the lead, because when you come to these kinds of presentations, it's sometimes worth knowing what's different. What are you going to tell me today that is going to be different to the others I've seen and the 50 others that I'll see whilst I'm at Health. And so, owing to my shorter attention span given my age, I like to just, within the first minute, just give you the value. And really what we've done here in this collaboration that we'll talk about, and we'll get to introductions and things, is we've pioneered a very unique model. Because we saw, and I think all of you saw, right, this MIT report that came out that said that 95% of pilots, AI pilots in enterprise are failing. And, our answer to that has really been, within the healthcare enterprise, our answer has been, well, how do we fix that? And the way we thought about it is we thought, can we actually do a very unique clinician deployment model? So that's the crux of it. It's really saying that we have all this amazing technology, and there are many great companies, but how do we deploy it effectively? And so what we did really was we have pioneered this approach. We sometimes call it a forward deployed clinician model. So at every stage of our AI, we have clinicians involved. So that goes, all the way to the design, to the kind of technology work that we're doing as a technology company. But also then when we partner with a health plan, we send in our own clinicians to deploy the AI and actually do a kind of peer-to-peer deployment. I'm going to talk about that, some of the lessons we learned, some of the improvements we've made to that process. And hopefully it'll be a really interesting sort of discussion where we can share some of those methodologies that we've used. So let me just introduce everyone on stage. So I'm Mustafa. By background, I'm a physician. You may have noticed the funny accent. That's because I practiced in the UK. And the interesting thing about being an outsider, not only being more of a technologist entering healthcare, but also being from the UK, is that you approach everything from a very first principles approach. You have this kind of naivety. Why can't we do this? Why can't we do that? Which is generally a good thing. But we've also seen how even big tech comes into healthcare and fails, right? And so what we've really tried to emphasize is then how can we actually partner with real healthcare experts, people who live it every day and have decades and decades of experience, not only on the health plan side, but also in the partners that we choose. So, I'm from Anterior. We're a clinician-led company, and we specialize in AI transformations for health plans. And I'm really, really fortunate to have our wonderful partners in HealthHelp sat next to me. So we've got Rahul, who's the Chief Medical Officer at HealthHelp, and then we've got George, who's the Chief Product Officer. And they'll tell you more about themselves. But we're going to tell you a little bit today about some work we did with Geisinger Health Plan. And I think many of you will know about Geisinger, but the health plan specifically has around 500,000 members, and they've done some really innovative work with us on AI and prior auth. So, Rahul, would you mind just starting a little bit, kind of describing the problem, specifically by telling like a patient story about what it is that we tried to solve?
Yeah, absolutely. So I'm going to walk through this simple case. 73-year-old patient comes in. I used to be a practicing internist. At HealthHelp, I've got 70 nurses, 50 docs, and it's been around 25 years. I joined 2 years ago. This is a classic case. 73-year-old walks into the doc's office, having some abdominal pain, some weight loss, and doc does some tests and says, comes back and you need a CT, right? It could be pancreatic cancer, it could be something bad going on. And then the request would come to HealthHelp. And this should be relatively straightforward, but abdominal pelvic CTs are actually pretty complicated. Very high radiation dose, ultrasound's often a better test. And there's a lot of back and forth between the nurses. You got to get to the right records, you got to look at the records, look at the guidelines, send it to the HealthHelp doc. Once it gets to someone like me, you can quickly give a thumbs up if they actually lost 10 pounds. If they lost 2 pounds, that's not really weight loss. So this process historically causes a lot of frustration, and that's the status quo. That is how most organizations do it. HealthHelp has MSK, cardiology, radiology, oncology, about 7 different specialties. So yeah, a lot of delay, a lot of frustration. The next slide kind of gets into, hey, what does this look like at a macro level? Around the country, almost 1 prior auth per person, obviously higher in seniors, lower in commercial. There's a funny stat, provider dissatisfaction, 95%. Who are the 5% of docs that actually like it or want more? I'd really like to meet them. and talk to them, say, yeah, that's interesting. The human reviewer quality, when you're an accredited organization, it's got to be 95%, otherwise you're URAC, right? They get upset. You got to show integrated reliability. So you make the bar so low that you make sure you get the 95%. But when you really look at how people are approving tests, it's not very accurate, the human side, both at the nurse level, and docs sometimes are worse because they just don't feel, some days, I think Mondays they do a lot more denials. We have to test this, George. So it's horrific, and it's not fun when you really look at, underneath. And I'm like, I came to this company 2 years ago. It's been around 25 years. We got to change this. So luckily, I met George. Yeah, he's been there a little bit longer. And but yeah, that's the challenge. That's the problem. It's messy. It's not clean. It's not accurate. And how can we use tech and AI?
So we met some really innovative leaders at Geisinger Health Plan. And together, Anterior as the AI company, and then HealthHelp as the experts in delivering service to lots of national plans and across decades, we partnered together. Because this is basically the question on the screen that I think a lot of health plans and across healthcare, a lot of great leaders are thinking about. They're thinking, hey, there's this amazing technology available. How can we use it to streamline some of these processes using AI? But more importantly, how does it actually work in production? I think that's what we want to share, some of those hard-earned lessons that we've learned by going on this journey. And just leading with the value, like what does that actually mean? Well, it means that that story that Dr. Singal just told about a patient, waiting potentially 10 days to get an approval, when if he had seen it immediately, if we were able to take his clinical brain and put it into a technology, he would be able to effectively, instantly approve. How can we make that into a reality? How can we make sure that patients don't wait 10 days, they're able to get instant approvals? So that's the mission that we set out on. And what's very important is that if you're going to do this at scale, if you're going to, if you do it in a very small way, you can have, 80, 90% accuracies. But if you're going to scale across millions and thousands of prior authorization requests, you need extremely high accuracies. So we were really, really sort of excited to share some of the stats from our work with the health plan in terms of, this is an F1 score, but just in general in terms of accuracy being very, very high. And then also the speed at which we were able to give those approvals being very, very quick. We're down to, on average, 155 seconds. So that's a review that might take 10 days from the whole process. But even once a clinician sees it, it might take them 15, 30, 45 minutes, depending on the complexity. And we're able to get that down to 155 seconds. So that's been really, really exciting. And how does that actually work? Well, one of the key lessons we learned is that actually a lot of clinicians and a lot of health plans and people in healthcare, they want to use this technology. They want to be helpful. But you can't give them another platform. You can't give them another window. They don't want to have this kind of swivel chair problem where you introduce more bloat into their workflows. So we actually embedded into the portals that they already use today. So where the provider already goes to submit the prior authorization request, where they submit the medical record, we just embedded into it. So we sit in the background. In fact, they might not even notice that we're there, but behind the scenes, we are doing a full review, the kind of review that a nurse or a doctor would do. So we take in the medical record, we take in the request, we find the right policy with our medical policy agent, and then we do a full medical necessity review, just like a nurse would do. And that's really what we brought. That's the kind of technology side. But then we brought that into the process in a way that was also very mindful of their experience and workflow as well. Now, George, can you add to this, actually? Because it's a little bit more than just pointing AI at the problem. There's a lot of infrastructure that goes into this, right?
Well, that's absolutely right. It's not just infrastructure, but as you launch technologies like AI, it's critical to have the right governance model in place to ensure you get optimal value out of it. And key word there is optimal. For us, for example, is critical, and one of the things that puts us apart from our competition is things like provider experience, clinical integrity. So it's critical that these kind of technologies enhance the strategy. Right? It's not just simple efficiency. So let's look at specific clinical integrity. We have put quite the governance in place where we have our clinical team that does consistent review of outputs of the AI technology, and works very closely with the clinical team that Anterior has And the shared notes review cases and identify areas and opportunities for improvement. Now, these improvements are not done lightly. There's a clinician scientist team on the Anterior side that guides the product team how to implement those changes. So the takeaway from this one is throughout this process of launching, maintaining, enhancing, there's a clinical oversight that gets back to that core of clinical integrity. That's very, very, very important for us. In addition to that, we work very close with the health plans. We don't just launch this, just turn it on blindly. We get approvals, we work with them, we do a lot of Q&A sessions to make sure they are very, very, very comfortable with the technology, with us, with our partner, before we turn them on. So that has been extremely, extremely successful. The second thing that's very important for us is provider experience. So we have actually a quote, if you go to the next slides. I won't read the quote, but this is a direct quote from a provider. I'm not naive. Providers don't like let's say what it is. However, they like ours better than the rest. And this is one of the reasons. Because as was mentioned earlier, what it used to get days in the past, now it takes seconds. There are cases many times where the patient is still in the office. The answer comes back with a positive answer, but they should have that MRI or they should have that CT. And they get that service before they leave the office. And the providers have noticed that. I've noticed that the number of cases that get an answer automatically, despite the number of pages that the case notes may have, has increased. It has increased visibly. And that is shown. We have actual data in our research on NPS, there we go, that we are off the chart compared to the industry. The industry, when it comes to provider satisfaction score in UM, is around high teens, I believe it's around 18. Ours is in the 60s, and that was last year. Wait till this year comes. So we clearly have seen through direct feedback from providers and through actual data in the market that this is actually working. We have hit it out of the park from day one, and we're very appreciative of this partnership.
I want to share a few lessons that we've learned from doing this. We've spoken a lot about 1 already, and potentially 4 as well. So let me just focus on 2 and 3, about this kind of clinician-to-clinician deployment model. We speak to many health plans, and one thing that a lot of them tell us is that in some of the AI implementations and pilots that they've had, one of the failure points, as well as maybe performance not being up to scratch, but another thing that's often not spoken about is the amount of burden that their teams had, right? So we've heard stories about national health plans spending 1 to 2 years on a pilot with a sort of technology team, and at the end not having anything to show for it, but also having spent a bunch of time and resource from their own clinical and operational teams, because often technology companies are sending in their engineers. And so you kind of have this cold start, or you have this problem where there's clinicians from health plans having to explain healthcare to engineers. So we've decided to shortcut that and actually just send in our own clinicians. So can we, if we're working in UM, can we send in our own UM clinicians to liaise with their UM clinicians and their operational teams? And so it's a peer-to-peer conversation. And that has a tremendous impact. So that's been something really, really effective for us. The third point around starting small, it's important to start somewhere and not get stuck in analysis paralysis. But when we started this, we started with just 9 CPT codes in diagnostic and imaging. And what we really focused on is, can we show impact really early? And once we had that impact, and once we had the buy-in, and once the teams had worked together, then we were able to expand to many, many more together. So that's been another lesson for us. But I'd love to discuss some of these, and the rest of the team are here as well to discuss many more of these with you. The final sort of lesson, and this came more from the Geisinger side, but we, as technology and clinical teams, we learn a lot from our health plan partners. And it's easy often to get excited about technology and talk about performance and accuracy and next generation models, et cetera, et cetera. And that's all very important. As I've said, that's important to operate at scale. You need all of those things. That has to be true. But what's also interesting is that when we partner, we can actually think about much more bigger and greater and downstream effects of some of the work we do together. Some of those are around, enabling better quality. So even if you don't speed up an operational or administrative process, can AI almost act in a shadow mode and just improve quality? That's a great outcome in itself. Another thing is around the relationship. George mentioned some of the provider feedback, which has been really great for us, but also the feedback from members and patients, which has been really awesome as well. So these are some of the lessons and some of the things that we're hearing from our partners. And the last thing, before getting to any questions that many of you may have, is around what's next. So today we, do some of the work that we described in automating and accelerating prior authorization across many service lines. And these are some of those. So that extends all the way to post-acute, inpatient, some of the more complex ones, owing to that kind of deep clinical expertise and AI expertise. Secondly, today at the top, we've told you about this 155 seconds, this just taking a couple of minutes. But what's the future of the industry? Well, actually, it looks more like 0 seconds. It looks more like sitting within the EMR as perhaps a Smart on Fire app. And actually, the provider doesn't even need to hit submit perhaps in the future, where they're able to just straight in their EMR get an approval and get guidance straight away. It could even be minority report style, where there's actually no prior auth submission process. It's actually, companies like us and the health plan is actually living in the EMR. That's really exciting. And the last part is that many of you will recognize, I just showed a workflow diagram. I showed, data coming in, some kind of process or rules being applied, and AI reasoning through that with really high accuracy. Well, that's a very, very generalizable approach. And many of you will know that a lot of your processes look very, very similar, right? So, prior auth, we've just talked about. But payment integrity, if you switch the tenses around, it's very, very similar. And many, many more workflows as well. So that's really work that we're already doing today, but we're increasingly expanding into. So thank you so much for listening. It's been really great to share this, and thank you to the KLAS team for highlighting some of this work. We'd love to open up for any questions from anyone in the audience, and also we'll be around the event for the next few days, so please come find us and tap us on the shoulder, and we'd love to talk. So thank you so much, everyone.
One question, I think if I heard you correctly, that a lot of the workflows you worked on was on the approval side, on the prior authorization. Can you talk a little bit about the barriers on the denial and how, what workways are needed to get in that direction as far as workflows or regulatory requirements, et cetera?
George, do you want to touch on this?
Yeah, I mean, obviously the approval is the fast track, the easy button, thumbs up, that's easy. Denials, initially, so AI can never deny, first off. When we started, the denials would go to the nurse and would highlight, hey, here's what's missing. Then they would re-review it and then escalate it to our physicians for review, just like any other review. Where we're headed is to bypass, because this technology is so good now, and the docs are like, just bypass the nurses. If it doesn't work, let us see it. And then if we have additional questions, we'll ask our nurses to go find the data, talk to the provider, schedule a peer-to-peer or whatever. So this whole, we call it tier 1, our tier 2, our nurse bypass, that's something we're going to be launching. That's super exciting. And then, if you're a health plan, right, you could free up the nurses to do population health, proactive management, something outside of UM. But yeah, super exciting, and thanks for the question.
No, I just want to say that and one of the reasons why it's in place is because the summary, the clinical notes summarization that comes out of AI is so precise and so well defined that literally the nurse looks at it and just passes it to the MD for review anyway, unless something is some additional information is required for the nurse to make a phone call. And that obviously goes back to that work that the different clinical teams across both entities have done to ensure that the outcome is at the right level of clinical description.
I have a question. The opening discussion from the KLAS analyst talked about upcoding and downcoding being two sides of the same coin from the payer and provider perspective. My sense is we now have kind of battle of the rev cycle bots. That's what's going on with that. That is what it is. Health AI in 2025 is battle of the rev cycle bots. Is that the right thing? Because we think about this, wouldn't we be better off if we actually thought about could AI actually be kind of a neutral umpire calling balls and strikes, not working for the health plan or working for the hospital system? Isn't that the better way to actually deploy AI to actually create efficiencies and really solve problems in our system?
Yep. And sorry, just to clarify the question, I totally understand about kind of the AI arms race that's occurring, right? And is there a better model to that? The question is can the AI be a kind of third-party arbitrator? Which is a really interesting point. I think today, and feel free to add here, but today we see the kind of, the guidelines and the best practice that we're developing as humans. We see that as a third-party arbitrator. Is there a world in the future where instead of having kind of competing AI bots, RCM, one side upcoding, one side downcoding, et cetera, you instead have AI determining that? Perhaps. I think today what the most interesting work that's probably closely related to that is that when you have this kind of AI involvement and this deep data layer, so that instead of a kind of review happening on paper and not really understanding how the human reasoned through it, when you have AI and you have a full auditable review that happened that you can inspect, and you can actually examine guideline by guideline, node by node, you can see the full chain of reasoning, well, that can actually go into those kinds of the guidelines that you're developing, the best practice that you're developing. So it can almost act as an insight layer today. But in the future, absolutely, I think that would be a very interesting world. It's a great perspective.
Yeah, and just to add to that, I was talking with Mac beforehand from K2, and we talked about agentic AI and the patient interview. What's super exciting is when the patient's telling you, hey, yeah, I've got knee pain, but it's not that bad. It's better than 6 months ago. Yeah, you get one of those 20, sorry if any of you guys have orthopedic surgeons as family members, 20% of those guys are still going to do surgery on mild arthritis. They're going to want and they might game the system. But with agentic AI and the patient's like, hey, it's not so bad. Physical therapy helped. You're kind of, I think the AI arbitrator, it's going to be super exciting to see how all this, gets fleshed out.
Okay. Thank you, Dr. Rahul, George, and Mustafa. Would you give them a hand as they leave the stage? Thank you. I would like to welcome Shana Tate from Ballad Health, and Jim McDermott from Epic is going to help her with the presentation. Unfortunately, her ensemble was not able to make it due to flight problems and delays. So, yes, thank you for stepping in, Jim.
Well, hello, everyone. See if I can get this to go. There we are. So my name is Shana Tate. I am the Chief Revenue Officer at Ballad Health. We are located in Northeast Tennessee and Southwest Virginia. We serve the counties, 29 counties in Tennessee, Virginia. We also touch a lot of patients in North Carolina and Kentucky. So we're right up there on the edge of the four states there. Unfortunately, my partner in crime couldn't be here, so I'll be representing both UHC, Ensemble, and of course, Ballad Health. And what we're going to talk to you today is about our partnership with Payer Platform, that's an Epic tool, and United Healthcare. So what is EMPA? It is a tool that is utilized through Payer Platform for any of you that are familiar with Epic and Payer Platform. And it's really just a way for us to talk bidirectionally with our providers and with our payers back and forth to create really efficiencies and automation around authorization. So it's a very useful tool, I will tell you. I'm a big fan of it. And so we decided that we would partner with United Healthcare to do this. So why did we do that? Well, as we all know, authorizations are very time-consuming, very inefficient, very manual. We can't get timely access to patient care a lot of times because of the time it takes. And then we, on the provider side, experience denials quite frequently due to authorizations, missed authorizations. And so we were looking for a solution on how we can become not only more efficient, but really focus on our patients and get them in quicker. So the results snapshot. So we did the partnership, and we decided to go with United Healthcare because they were probably the most progressive at the time. They were the most willing payer, and they are a large portion of our payer mix. So we implemented it. And just a little bit about what we did and how we did it. You'll see on the screen, Ballad's about a $2.4 billion organization just on the acute side. We are an integrated healthcare system, so we have providers, We have post-acute, we have retail, but just on the acute side, this is where our focus was, is our 21 hospitals. And we really, I guess, narrowed it down to certain eye plans, payer plans with United, so we didn't go all out, number one, and we only did imaging, certain imaging, so MRIs, CTs, we didn't really go much out beyond that for the pilot that we did. So you can see on the screen, obviously I'm not going to read all of it to you, but essentially we were very successful, and from my seat, I was probably the most, I'll say, worried that our wonderful payer partner would try to utilize this to shift denials around. So one of the things that we did was, not only did we understand that we're now more efficient, so we went from 3 days average authorizations on the outpatient side to less than 1 day, but I really wanted to see what our denial experience was. So I was concerned that they would not only shift, but then we would also see things like requests for information. We'd see that go up. And so we took about 8 months of data in watching these specific accounts and watching our overall denials to see where that shift may have occurred and if it did occur. So it didn't, so I'm very happy to say it didn't. We were very impressed with our payer partner that we didn't see that shift, and we do continue to monitor that just to ensure that that's happening. The other thing I want to point out is there's a lot of confusion or misconceptions about payer platform, particularly EMPA, that when you're normally submitting for an authorization, the provider is picking the document types. They're saying, okay, I need to send these 3 things and send it to the payer. You upload it to the portal. Some of us still fax it. And so payer platform, all that did was automate it. So we controlled everything that the payer received. They do not have full access into our system from that perspective. So I just wanted to point that out because that's often a question that I get, and it's often a misconception, and even my own misconception when we started down this road. But you'll see that we went from, I'll say 0% touchless to 84% touchless. So 84% of our authorizations when we went live with Payer Platform had no manual intervention on the payer or provider side. So if you're thinking about maybe looking into this and diving into it, what were some lessons learned? I'm going to say 3 big ones. Ensure you have buy-in from both the payer, your provider, and the organization. So not just buy-in from the leader of revenue cycle or maybe the person on the payer side that's doing the implementation. You've got to have buy-in, especially executive buy-in. What we learned was there was, again, back to the misconceptions about payer platform, that we didn't have a lot of support at the senior executive level because they thought now we have a payer that has full access into our system, and it was going to create a lot of downstream impact to our cash. So that was the first biggest lesson learned. The second one is always align on the goals. So this is between the provider and the payer. Align on your goals, what processes you're going to take to do that, and then what are the action plans if necessary, to get things back in line. So we were kind of a little bit all over the board, like, oh my gosh, it's like a fire drill sometimes, trying to get ourselves back in line. And then lastly, that very last bullet point, ongoing support, key metrics, and sharing with key stakeholders. So communication is always key in everything we do, and it's really important that you communicate that out beyond the little circle of revenue cycle and beyond out into the organization. So what's next? So for us, we are going to continue to move forward with opening up Payer Platform more. We're going to not only go further with UHC, but we also have other payers already standing at the door wanting us to move forward. The main reason is the efficiency it creates both on their side and our side. I will tell you the challenge we have right now is IT, and I'm just by a show of hands, how many people here actually use Epic? Or your system uses Epic? Okay. So Epic is probably one of the greatest EHR systems that I've seen, and I've seen a lot through my career. But it takes a lot of resources to keep that going. So for us, the challenge right now is IT and making sure that we have certified people that are in there helping us. And so we're kind of a little bit at a standstill while we're trying to get there. But we are going to continue to move forward. That's our system goal. And we are going to replicate this with other payers as we go along. So, any questions? I know that was quick because I'm fighting against lunch. So, any questions? Yep. Here's one up here.
Hi, you mentioned expanding to other payers. Do you also plan to expand to other types of services? And if so, do you anticipate any challenges unique to certain specialties?
I'm sorry, there's an echo. Did you hear that good?
I think his question was, in addition to expanding to other payers, are you looking to expand to other specialties outside of radiology? And do you expect any challenges?
Great question. Yes. As a matter of fact, we are going to be moving forward on our physician side as well. So we are going to be expanding as many specialties as we can, and we're going to bring in our physician partners. Yep. All right. Any other questions? Good way to save money. Tell your executive team, move forward. All right. Thank you very much.
Thank you so much, and thank you all for coming. If you would like any further details, you can pick up your phones, and there is a QR code. Mac, I didn't see you. Go ahead.
No, thank you, everybody. We're again very grateful for you being with us this afternoon. Yeah, the one on the left here is what we call our collaborative brief. So the summit we held in this year, 2025. I like to say last year, but it was 2025. In May, we actually have a report that you can access and download all the content from that. And then on the right, we have the details available for those of you that would like to join us in Salt Lake. Again, this is an open event. It is by invitation to that point, but you can just reach out to us. We'd love to have payers, providers, other teams that sit at that intersectionality that would like to join us. Again, we welcome you to be there. One last time, let's give a round of applause for all of our presenters today. Thank you, everybody. And we hope to see you again. Come and talk to any of the staff here, Aurene or myself, if you have any questions about KLAS, K2, or anything else. Thank you.